Okay, so hi everyone. And do you see my screen, Dr. Arlen?
Yes, I
Yep.
do.
So hi everyone, my name is So hi everyone, my name is Sophia and I am Mac's seminar coordinator. So I just want to say thank you to everyone for signing up to our seminar today. And today we have Professor Arlen, who is an orthopedic surgeon and has broad experience in upper and lower limb orthopedics, excluding hand surgery. He has extensive experience in orthopedic trauma management, and his subspecialty interest is arthroplasty surgery. So to show respect to our presenter, I'd like to ask the attendees to mute themselves during the presentation, and we'll have a little Q&A session at the end where you can unmute yourself and come forward to ask questions. During the presentation, if you have any questions, please pop them in the chat box below, and we'll attend to it during the Q&A. Now over to you, Professor Arlen.
Thanks, Sophia. Okay.
Yep.
All right. Afternoon, everybody. I thank you for your time. I'm an orthopaedic surgeon still in clinical practice, and I obviously do medico-legal work as well, and some medical negligence work. So I'm trying to make this as simple as possible. Some parts of what we're going to discuss are a bit technical, but I've tried to make it as easy for everyone to understand as possible. The outline of this talk is a little bit of history, what people can expect from modern total hip replacement. We'll go through some of our Australian registry on some of the common causes of revision. We'll go through some of the mechanical and soft tissue causes of pain and instability. And I guess most importantly, what are the reasonable expectations and when does that fall short of the test of reasonableness? So, right. So,
Yep.
the first hip replacement was put in 1953 in England, but everybody in Europe and America has claimed putting in the first joint replacement, but realistically, reproducible joint replacements didn't occur until the 50s. And even then, the longevity and the results were not great until Sir John Charnley came along, developed his prosthesis, a few false starts, but eventually he produced one which was quite reproducible and had good long-term results. And then we move on to the modern hip replacements, which are far more sophisticated. They're modular. They incorporate a lot of modern metals and ceramics and much better plastics than were available back in the original period. Next slide. So this is from our National Joint Registry, and it shows the results of conventional total hip replacement. You see we're out to 22 years now, and the survivorship, and I stress survivorship rather than whether it's a successful result or anything like that, is still 90%. Next slide, please. So these are the common reasons for revision, which are on the registry. Infection is still, despite our best efforts, a significant cause of a lot of revisions. And I don't think it's going to go away anytime soon. I'll explain to you in a minute why that is. Fractures occur. Prosthetic dislocation is still a significant cause. Loosening is still a significant cause. Indeterminate pain, leg discrepancy, malposition, and all those other smaller ones there you can see. Next slide. So age for revision is definitely a variable, and the younger the person, the higher your risk of revision. But in spite of that, the results, even in people under the age of 55, are still very good. Next one. So there is really no difference in the outcome for males and females. Next slide. One of the biggest problems we face, and it's only going to get bigger, pardon the pun, is that obesity has a significant impact on the outcomes of hip replacements. And unfortunately, as you can see from the graph here, there's only 25% of people are of normal or underweight. So 75% of the people we operate on are pre-obese or obese. It's a pretty sad reflection on our society, but that's a reality. And can I have the next slide, please? The implications are not good from the point of view of results. You can see here that the more obese you are, the higher the risk of revision. And if we go next slide, you can see here that the risk for morbidly obese people is 6 times greater, and the main risk is for infection. And as I say, a greater and greater percentage of people requiring joint replacements, a greater percentage of people are overweight, and therefore we're going to continue to have problems with infection in these people who are metabolically challenged. Next slide, please. So one of the aberrations that's occurred and is probably not so important now as it was 10 years ago was the impact of metal-on-metal bearings. And there were some dud ones out there without a doubt, and they had some terrible results. There's still people doing metal-on-metal hips. Those ones have generally got a good track record. And there are certain designs with metal-on-metal which have been shown to be useful in younger patients. But some of you may recall that the ASR and some of the other total hip resurfacings had significant problems with wear, which caused catastrophic amounts of metallosis and damage to the tissues. Most of those have been probably revised by now, that are going to be revised, but there's still people presenting to this day with problems with metal disease, which can manifest itself as local, and also people can get systemic problems related to high metal ions. Next slide, please. Infection is one of our biggest concerns, and this is one of the issues that may be improved by some of the new biomechanical and biochemical applications that we use in the future. Yeah, next slide, please. So part of our role is obviously to identify high-risk patients, and this is an aspect which has been, I think, impressed on most orthopaedic surgeons, and most orthopaedic surgeons would go through a sequence of, or a checklist of various conditions which are known to be associated with a higher risk of complication. Certainly, if people got multiple comorbidities, including cardiac problems, they'll all go and see their cardiologist before they have the surgery. They're morbidly obese, who will endeavour to try and get their weight under control, or even send them to a bariatric surgeon. Pardon me. And obviously, we want them in the best possible physical shape before they have their surgery. Preferably not have had any significant thromboembolic events beforehand, which would need to be managed with anticoagulants. So there are several risk factors for infection. I'm not going to go into this in detail, but as we've already alluded to previous slides, obesity is probably the biggest one, but that obesity and diabetes go hand in hand. But there are other lists of things which have shown to be a higher incidence of infection. Next slide, please. Some predictors of poor outcomes. Some are pretty self-evident. People with substance abuse, have poor general health. Quite often it's associated with long stays in hospitals and 5 times the mortality in some studies. Anybody who's taking a large amount of opioids preoperatively is bound to require a large amount of opioids postoperatively, and that's associated with increased complications. Poorly controlled depressive illnesses also are a predictor of poor outcomes, and low back disorders too. So they have and I'll go into this in some detail, a higher risk. Next slide, please. So there's some predictors of increased pain, which is, as I've already mentioned, preoperative heavy analgesic use, psychological disorders. Obesity is associated with increased pain, multiple previous surgeries, and people who are dehydrated in the postoperative period. Next slide, please. So we're looking at the causes of pain. Obviously, if something is loose in there, then that would be a significant rationale for pain. Let's go back, please, Sophie. So dislocation, subluxation, malposition of components, which can impact on the stability of the prosthesis, can result in contact between the components in various positions and also soft tissues. Leg length discrepancy, abnormal wear, osteolysis, impingement, and as I mentioned above, with components or with soft tissue. There are other peripheral conditions like bursitis, and then we get into infections and fracture and spinal disease. Next. So common complications here. I'm not going to go into these at all. We go to the next slide. So what we ideally want is a solidly fixed components, no exposed part of that prosthesis around the acetabulum that might have some soft tissue impact. We want to re-establish the three-dimensional spatial arrangement of the hip with all the relative angles between the femur and the acetabular component. We want it to be stable throughout a range of motion. And we need to compensate for other extra anatomical factors, in particular spinal disorders, which may have an impact on the relative position of the acetabular component, stiffness or leg length abnormalities in opposite joints, which may also have an impact on it and may require us to make some alterations in our operative approach and how we design. Right. Loosening, most of the time, it's pretty self-evident, with the component rotating around, being obviously quite loose. But at other times, it's not, and we may have to get various scans. One of the difficulties we have is, of course, these metal components, we can't use things such as MRIs because there's just too much artifact and you can't really interpret things. So bone scans become quite useful. And here you can see on the right, increased uptake around the upper end of the femoral component, which is associated with an area of loosening. Next, please. So dislocation and subluxation, still a fair incidence. We've tried to address this with different types of components, with different approaches to the hips, and they have helped to an extent. And the incidence of dislocation has reduced in the last 20 years. There are various things which will lead to a dislocation. As you can see here, when there's any bony contact, it can create a levering force on the hip. If the metal parts impact against each other through a range of motion, that may get the component to sublux or dislocate. And as we were talking about before, the spinal orientation which may be affected by just spinal disease or previous surgery, can alter the effective alignment of the acetabulum. In a normal, healthy young person who's standing, their acetabulum faces directly to the ground, which you can see in that middle image there. But if there's a change in, and there is a little bit of variation in that, but if there's a change in the angle of the lower part of the spine, you can see how that would impact upon the relative alignment of the acetabulum relative to the ground. And secondarily, this has an influence on the stability of the hip. There are other things like soft tissue tension. Some elderly patients with very poor tissues have a higher risk of dislocation. And there are things that we try and do to address those particular situations. We have probably a lower incidence of dislocation when we do anterior replacements of the hip. We certainly need to get a good spatial arrangement of the hip to ensure more limited risk. But even with ideally arranged hips spatially, if the orientation of the socket is out in any way, that can lead to some degree of impingement when you're sitting or standing or twisting on the leg. Have the next one, so when we got malposition or leg length discrepancy, this is something I see from time to time for opinions. If it's too short because the prosthesis has been embedded in too far, that creates two problems. One, a stability issue because there's not the tension in the muscles there. Second is it has an impact elsewhere, both on the other hip, which may be an issue if there's a hip replacement on the other side, because all of a sudden it is more inclined, the acetabular component, from where it should be in the normal anatomical situation. It also has an impact on the lumbar spine. And it can ultimately impact on the knees as well. If you look to the right there, this is a patient who had a 17 millimeter leg length discrepancy. And this had a severe impact on this patient's back, as well as locally around the hip replacement. This particular patient complained of it actually from the time that he was in the wards after the surgery. For some reason or other, an X-ray that was taken wasn't reviewed. Patient went home, and then at the 6-week review by the surgeon, complained about it, and at that stage, it became a very difficult problem to address. So we go next. So abnormal wear and osteolysis. So here on the top left-hand corner, you can see the common articulations. There's metal on polyethylene, metal on metal. As I say, that's not used nearly as much as it was. Ceramic on ceramic is very commonly used, and also ceramic on hardened polyethylene is quite commonly used as well. The difficulty is if you get substantial wear, either metal or plastic debris, it leads to particles which contract around the prosthesis and ultimately lead to some what we call osteolysis, where the bone gets resorbed away. And you can see in this middle one, those little cysts in the bone up around where those screws are pointing. And you can see where it's worn into the plastic because it's eccentric, the ball in the socket. And those little cysts have been completely eroded away. On the far right, this is a patient who had a metal on metal component, and it's led to what we call a pseudotumor, which is the metal debris causes this intense reaction around it. This that little pile of debris, which you can see there, that big amorphous mass, is what was removed from the hip. This led to gross destruction, not only of the soft tissues, but also the bone, and ultimately loosening of the components and dislocation. Next one. They're fairly extreme cases, I've got to say. Now, impingement we talked about, and on the left, that's bone on bone. On the bottom, it's metal on metal. And on the right, there's a soft tissue component. And probably the most common source of pain around the anterior aspect of the hip following a hip replacement is quite often due to some soft tissue impingement of the psoas tendon against the edge of the cup. Next one, Sophia. Bursitis around the point of the hip. It's very common. It's been quoted as between 3 and 17%, depending on the studies. And this can be exacerbated by over distracting or extending the offset of the hip when you put a hip replacement in, which leads to some tenting of the soft tissues, which track over the trochanter and causes increased irritation. So occasionally, if these don't resolve with stretching program, with cure injections, you need to go back and lengthen those tissues around there or adjust the hip prosthesis. Next, please. So spinal causes of hip pain. This is a very complex area because everything's interconnected, and if there's degenerative disease in the lumbar spine, that can cause some nerve root irritation. I mean, most common presentation for people with this disease is some sort of sciatica, but if it's in the upper part of a lumbar spine, it can actually be pain represented around the groin and into the anterior thigh region, which is confused then with hip pathology, because the majority of people who have arthritis of the hip will present with groin pain, but more often over time, it'll progress down the leg to involve the knee and occasionally down to the foot and ankle. And some people only present with, say, knee pain when they've got osteoarthritis of the hip. So there's a lot of variation, and certainly if there's any non or atypical presentation of pain, it's always important that you investigate the spine, which incidentally is a reason why I end up seeing quite a few patients because they've had a hip replacement and it hasn't sorted their pain. And unfortunately, in some of those instances, they haven't been investigated for their spine before they've had that surgery, which is really a bit, a bit of a problem for obviously the surgeons, and it's something that should have been examined before, particularly if there's a atypical presentation of pain. We go to the next one, please. So we have a condition called the hip spine syndrome, and over 80% have significant back pain in their lives. Over 80% of people having total hip replacements have abnormal spinal x-rays and scans. And as I said, association between back pain, ridiculous symptoms, and a history occurs in up to 50%. So you have to go to some lengths to be certain that the problem is emanating from the hip to start with. And first port of call for most orthopaedic surgeons they would be referring the patient to a neurosurgeon or spinal surgeon for assessments before they do a total hip replacement. Because the last thing we need is that the patient has their surgery and still has pain. Certainly, there's no good excuse for not going through that management algorithm. So, as I say, isolated groin pain occurs in less than 20% of hip pathologies. And as I explained to you before, the pain can radiate everywhere. The next slide, please. The principal causes of hip instability are obviously not getting everything orientated ideally. And certainly surgeon experience can be a factor, and mobility of the lumbar spine. Next slide, please. So surgical approach has been linked to varying degrees of instability, and argument rages about anterior, posterior, and there are certain other external factors which are going to be a factor as well. How well you repair the capsule around the hip, level of obesity, that certainly is a factor. People have got big fatty aprons and very bulky thighs. They're going to lever on their hip a lot more than if they were lean. And there's certainly a relationship between the way the socket's orientated and the way the femur's orientated, and how much offset that you have, and the size of the ball on the hip has been shown to have an impact on the stability as well. So if pain and instability are expected complications, when does it fail test of reasonableness? Well, look, we now have an enormous amount of technology available. And although some of that technology is not available in every hospital, there are multiple things that we can do to try and ensure that the hip is going to be placed exactly where we want to place it, in the orientation we want to place it, and to minimise the risk of either impingement or dislocation. So we've got 3D planning, we've got X-rays, we've got simple X-ray templating, we've got planning software, we've got leg length guides, we've got intraoperative imaging, we've got robotics, we've got various algorithms for spinopelvic orientation. So ignoring or failing to investigate is probably the most common thing that I see for patients who present with ongoing instability or pain after a hip replacement. Next, please. So this is how sophisticated or unsophisticated it can be. You can see on the left, it's just using plain X-rays and little templates to work out roughly what size you're going to put in. But then you've got 3D templating, which can give you size of the components that you're going to put in more accurately, the orientation, the leg length, and then you can do planning, which will tell you how far with that orientation you're going to be able to move the leg before it starts to impinge. Okay, next. There's some of these things are obviously not available in every hospital. Robotics are more the province of private hospitals, but every hospital has an imaging system, and using a combination of fairly simple planning and intraoperative imaging, you minimise your risks of over lengthening, undersizing, oversizing, producing something which doesn't match the other hip. And so without using this sort of technology, you're depriving yourself of the advantage of trying to get a hip which is spatially accurate. So we talked about the hip and the orientation. I quite frequently do X-rays on all my patients after the surgery, both with them sitting and standing, to look at the the potential for there to be any impingement. Obviously, we look at the X-rays to see that there's good coverage of the components, so there's no, anterior lip of metal that might be catching against the tendons at the front or the back. Next slide, please. Okay, so that's a bit of an overview. I'm happy to take any questions.
If anyone has any question, please unmute yourself and just come forward.
All right. So here is the question from Sophia. How effective do you think falls prevention training is at an intervention?
Falls training obviously has an impact on reducing the risk of fractures, and also with elderly patients who have hip replacements, obviously a fall is a significant risk factor for dislocating their hip. So that's I think quite crucial, and it's generally part of the rehabilitation program of most physiotherapists and occupational therapists after surgery. It's generally the patient population where I'm operating on is mainly in the private hospitals these days, and their average age is generally less than those in the public hospitals, and it's the elderly people who are obviously at greatest risk. Fortunately, generally simple programs will deal with the issue with most people, and you get to a point after, say, 3 months when the risk of dislocation is extremely minimal. Most of the problems generally occur within the first few weeks of the surgery. Does that answer your question?
Yeah, I think so. I will let Sophia know about that. Thank you very much, Doc. Is anyone here have any questions for our doctor? All right. I assume that all of your presentations answer all of the questions here. Thank you for your time, Doc. And yeah, thank you so much once again for your insightful presentations and for your time. We will publish the recording on our YouTube channel soon after editing the video, and we'll send you the slide. We do apologize for the internet disruptions at the end. And if
hour, is it?
Yeah. Yeah.
System's overloaded.
Yeah, I think so. Okay. So I think we done here, and thank you everyone for joining with us today. Hope to see you in our next seminar with Mark as well. Thank you.
Okay. Bye.
Bye, Doc.
Okay.